All right, folks. So, welcome to newer approaches in menopause, or at least some evidence that is new that we will continue. And as you guys know, this is the logo of the medical clinic that I started recently over here in Pickering, Ontario, right? So, HealRx is the name of it. I know a lot of IMGs have reached out for possible observership opportunities and all of those, right? And I have responded to a lot of them as well. But this is just something that I wanted to share with you guys, some news and stuff about it. Okay, so let's get started on newer approaches in menopause. Let's start with a question. So read the question, think about it, and answer. All right, very good, very good. 39-year-old woman presents with 6-month history of irregular menstrual cycles, bothersome hot flashes, etc. She reports occasional palpitations, facial flushing, physical examination is fine, vital signs are okay. What are you going to do next, right? Are you going to just be like, yeah, you're fine, go home? Or are we going to do some investigations and stuff? So what's the correct answer? Correct answer is B. Order FSH and serum estradiol levels. Why? Why so? Well, the patient is under 40, right? So we need to make sure like what's going on, right? So why are there irregular menstrual cycles, right? So key thing in investigation is FSH for sure, right? This is a MCCQ1 high yield stuff, right? This is very important for you guys to know. And she has some symptoms, right, like palpitations and flushing and all of that. So we need to make sure that the hormone levels and everything, thyroid, all of that is completely normal in this case. Once we have that, then we move on to the next step. Okay, so answer is B. So why answer B, right? So let's take a look at the evidence and let's explore it a little bit more. So diagnosing menopause. Okay. So for females more than 45 years of age, the diagnosis is clinical, right? It's based on symptoms. Amenorrhea, hot flashes, all of those are the symptoms. We usually don't do any lab tests, right? We usually don't do any lab tests. Okay. And if they're sexually active, not using contraception, consider a pregnancy test. Okay, consider a pregnancy test. So this is for people more than 45 years of age. For females less than 45 years of age, right? We do investigate at times. So we order FSH levels and stuff like that to make sure that this is nothing organic, right? To make sure that this is nothing organic. Good. And for females that are less than 40 years of age, we do full workup. All right. We do full workup. You have your full hormone profile. FSH, LH, estrogen, progesterone, testosterone, prolactin, thyroid, TSH, all these hormones we include in the full secondary amenorrhea workup, right? And beta HCG and stuff to make sure that we rule out pregnancy. Very important for all these things, right? So this is age-based classification, age-based approach to amenorrhea slash irregular periods slash possible menopause and so forth. Is that clear, everyone? Yes, no, yes, no? All right, perfect. Okay. Now let's talk about some atypical symptoms, right? Like let's say a 46-year-old female came to you with hot flashes, palpitations, low mood, insomnia, all of those, right? Most of the times, 99% of the times, this is going to be menopause, right? This is going to be menopause. However, in some cases, right, in some cases, if the symptoms are unusual in pattern or frequency, right? Hot flashes all the time. In 24 hours, gets 2400 hot flashes, right? They're not accompanied by anything else. So just palpitations, okay? Just hot flashes, nothing else. You need to investigate it further, right? Why are there palpitations? Is there a cardiac arrhythmia going on, right? Should I be doing Holter monitoring and stuff like that? So you need to investigate that. Same with other things, palpitations, excessive sweating, diarrhea, something like that. Is there like carcinoid syndrome going on, right? Or palpitations, hot flashes, pheochromocytoma, right? Headaches, is there pheochromocytoma going on? Okay, very important. You need to consider and investigate depending on what type of symptoms are present, right? So that's your key thing over here to identify any of these red flags. All right, let's do next question. All right, all right, all right. 52-year-old woman presents with moderate to severe vasomotor symptoms that have persisted for over a year, right? She has difficulty sleeping, okay, and reports mood swings affecting her life. She is 2 years postmenopausal. Perfect. So based on all of these things, right? Based on all of these things, we know that this is menopause and she needs help with it. Good. Her medical history is unremarkable, but her mother had breast cancer at age 78. Okay, so mom had elderly breast cancer, right? It was not at young age, it was at old age. So she's at risk for sure, but not like super, super high risk, right? BMI is 32, so obesity, right? So that's another one. Hmm. Mother had breast cancer, so that's another one too. She consumes 1 to 2 glasses of wine daily. That's not as bad. She has not used hormone therapy before. Okay. She asks about treatment option and long-term risks. What would be your recommendation in this case, right? So let's go through it one by one. Initiate combined estrogen progesterone therapy as her symptoms are moderate and breast cancer risk is not relevant at her age. Well, the breast cancer risk is relevant, right? It's low, but it is relevant. So we will keep this here for now. Next, avoid hormone therapy due to her family history and offer only non-hormonal options. Well, the history is not like super bad, right? So you are not like, oh my God, I'm going to avoid it fully. No, not like that, right? Because it's not like fully bad history. So none of this, right? Recommend transdermal estrogen with progesterone due to her elevated and breast cancer and venous thromboembolism risk. Okay, this is third option. Good, good, good. Start oral estrogen alone because the WHI trial showed lower breast cancer risk with estrogen only therapy. No, anytime somebody has a uterus, you give them a progesterone as well. right? Anytime somebody has a uterus, you give them progesterone as well. Last one is delay hormone therapy until after 60 to reduce cardiovascular and stroke risk. This is actually not right. Okay, we'll talk about this evidence after, but this is actually the opposite. This is incorrect. You need to start before 60 for good cardiovascular outcomes and stuff like that. Okay, so far, one, two, three, we have already taken out. So we have two things now. We have A or C, two options. Should we go with A? Should we go with C? Right? So A is combined estrogen progesterone therapy, and C is transdermal estrogen with micronized progesterone. What do you think you will give? Will you give somebody oral stuff, or will you think you'll give somebody transdermal stuff? What do you think you'll give? Very good, Dr. Marwa. Absolutely. Transdermal stuff has way better, way reduced risks compared to oral stuff, right? And we'll talk about all of this evidence in the next few slides. Okay, a little bit difficult question, but I wanted to cover it. Good. So within 10 years of menopause, so she will benefit for sure. She has risk factors for breast cancer and stuff, right? Micronized progesterone has lower breast cancer risk than synthetic progesterones. Okay. Transdermal estrogen, like I said, lowers other risks, and we will talk about it, right? Estrogen alone you cannot give because it increases the risk of endometrial cancer, right? So if she had hysterectomy, sure, you could consider estrogen alone, right? Perfect. And last one, like I said, this one after 60, no, it should be started before 60 for cardiovascular benefits. Okay. So let's go over all of these things. Let's look at the evidence and see how things are. All right. Treating menopause, hormonal versus non-hormonal treatments, right? So the decision is based usually on risk factor, contraindications, patient preference. So let's talk about this. Q1 many times ask questions like that as well, right? It will give you a case, whatever 52-year-old is menopausal, and then they will give you some risk factors. Recently had a stroke, recently had a brain bleed, recently had a pulmonary embolus, right? And then they will say, what management option will you choose? So you have to do risk benefit analysis around what is a risk factor and what would be the best possible treatment in this case. Good so far, everyone? Yes, no, yes, no? All right, perfect. Okay, let's move further. So treating menopause, right? So let's talk about hormonal stuff. Non-hormonal, I know you know, non-hormonal we'll talk about some other time. But today I want to cover mostly the hormonal stuff, right? So first line treatment for vasomotor symptoms. It is usually the first line treatment for vasomotor symptoms. So that is usually your hot flashes and stuff like that. Hormonal treatment many times is the first line, right? It is recommended by Society of Gynecologists and so forth. Okay. It is effective in both peri and postmenopausal patients, right? Peri and postmenopausal patients both. It reduces hot flash night sweats by 75%. Best option. Okay. What are the types of hormonal therapy? So you give one hormone, which is estrogen, right? Which relieves your vasomotor symptoms. And along with estrogen, you give progesterone, which protects the endometrium from like cancer and stuff like that. Like I said before, you can use estrogen alone if they had hysterectomy, right? Now, what are the forms? So you can have oral, so you can take pills, right? Like Premarin and so forth, Provera, right? Oral pills. You can have transdermal, so patches and stuff you can use or gels you can use. And there are vaginal tablets, rings, all of that you can use too. For progesterone, you can use IUDs like Mirena, you can use that too. Okay. If you use transdermal, it avoids first pass metabolism, and transdermal estrogen has a lower risk of clots, right? Lower risk of clots, lower risk of stroke, and so forth. So transdermal, slightly better, right? Somebody, let's say, had a TIA, or for example, somebody had a history of something like this, and you had to choose a hormonal therapy, you will choose transdermal over oral. Okay, perfect. What are some of the newer treatments that are available for menopause, right? So do you guys know about this bazidoxifene and stuff like that? Selective estrogen receptor modulators. Yes, no, yes, no. Do you guys know a little bit about it or no? No? Okay. So these are selective estrogen receptor modulators like raloxifene and tamoxifen and bazodoxifene and a lot of these guys, they go and act on specific receptors, right? Specific estrogen receptors. So this is a newer class. They call it TSEX, right? Transdermal selective estrogen conjugates, right? There are selective estrogen conjugates and stuff like that, right? And a lot of them are combined as well. So they offer good benefits, right? They offer good benefits and stuff. Okay. Um, and then you have tibolone, which again is another synthetic compound similar to traditional therapy, right? They are now available in Canada. Are they widely used? No, no. They are not widely used, right? Still widely used in menopause, still widely used in menopause is non-hormonal therapy. So like your venlafaxine, right? Your SSRIs and stuff like that. This is still widely used. We are gradually switching over to hormonal therapy. Hormonal therapy had a lot of scaredness associated with it because of cancers and stuff like that. But now we are understanding the risks benefit. We are understanding it a little bit better. So we are prescribing it more and more to improve the quality of life of females who undergo menopause. All right. Now, clinical consideration. Who do we give these treatments, right? So, ideal for patients less than 60 years of age. Okay, ideal for patients less than 60 years of age or within 10 years of menopause, right? Within 10 years of menopause. How long should you give it for? There is no limit, right? Previously, we said will give it for 1 year only. They said it should always be evaluated at 5 years, all of those things. No, they say that you should always evaluate any therapy, whether it is therapy for diabetes, therapy for menopause, anything, you should evaluate it, right? And you should individualize these treatments, right? You should individualize these treatments. Good. Anytime someone has premature ovarian insufficiency, right, like a 30-year-old and all of those, you need high doses of these hormones, okay? Otherwise, they go into menopause, they have severe symptoms. Good. Continue therapy to average menopause age if started early, right? So you can continue up to 52 years, whatever, 50, whatever the average age is, if you have started at an early age like 32, 33, because of premature ovarian insufficiency. All right. Testosterone. Are you guys aware that testosterone can be given to females with low libido? Are you guys aware of that? It can be given to females with low libido. Yes, no, yes, no. No? Okay, perfect. So this is a great new piece of information for you guys, right? So testosterone use can be, it's off-label use, right? It's off-label use. But testosterone can be used for low libido, hypoactive sexual desire, right? Again, new piece of information for you guys. Awesome. Let's talk a little bit about benefits, right? So this I'm not going to spend too much time on because you guys already know this. So symptom relief, right? Like vasomotor symptoms improve, sleep improves, all of that. When they get estrogen and stuff, the local vaginal tissues become nice, plump, all of it. So all that dryness, atrophic vaginitis, all of those things improve really nicely. Cardiovascular benefits. So this was one of the options in our question that we did before. So if you start less than 60 years of age, it reduces coronary artery disease risk, right? It reduces coronary artery disease risk. Bone health, you guys already know, right? It reduces the fracture risk, reduces the risk of osteoporosis, and so forth, right? It helps with insulin sensitivity and may reduce diabetes risk as well. Okay. It also helps in improving lipid profile and all of those things. Those are some of the good things. What about the bad things, right? So breast cancer, there is slight increased risk with breast cancer, right? With combine estrogen and progesterone, right? If you use micronized progesterone, right, it has a lower risk. If you use synthetic progestins, it has slightly higher risk. Okay. And you can consider other TSACs and stuff like that in some patients too. Strokes and clots, we talked about before, right? In women more than 60 years of age. So in older females, the risk increases, right? The risk increases. And thromboembolism risk as well, right? It slowly increases. But remember, guys, most of these risks are for females more than 60, right? Are for females more than 60. So less than 60, it is still a great treatment to use dependent on their risk factors, right? And transdermal estrogen has lower risk than oral for any sort of DVT, PE, all those things. All right. Now, how do you start it? Right? Somebody comes and says, Doctor, I want hormonal therapy. Sure. What will you consider? Right? What will you consider? So you will look at breast cancer risk, you will look at stroke risk, you will look at VTE, right? Any history you had DVT before? No? Okay. What about pulmonary embolism? No? Okay. Have you had like any myocardial infarction, any strokes, anything like that? No? Okay, okay. What about in family? Did your dad have a heart attack at the age of 40? Oh, okay. Do you have familial hyperlipidemia? Oh, I didn't know that. Okay, okay, okay. What? Your sister had invasive breast cancer at the age of 40? Wow. Okay, okay. So these are the big risk factors, right? So risk factors we need to cover. And dependent on risk factors, we provide them with options for hormonal therapy. Good. What else? Uterus protection, you guys know, I told you, right? If uterus is there, you have to give progesterone. Okay. And then cost and stuff, you don't have to worry about it for now. But when you start practicing, you have to think about cost because a lot of patients can't afford it, right? A lot of patients can't afford it. So I've given some examples over here, right? Like breast cancer risk, consider TSAC and stuff like that. Venous thromboembolism risk, consider transdermal products rather than oral products. Okay. Now let's take a look at some of the adverse effects and stuff, right? Like once you put somebody on HRT, what are some of the adverse effects that can happen? So two most common, right? One is vaginal bleeding and second is breast pain or mastalgia, right? Vaginal bleeding and second one is breast pain or mastalgia. So anytime there is a change in hormones, right? Like for example, you start somebody on oral contraceptive pills, okay? When you start somebody on oral contraceptive pills, they can have irregular periods too, right? And then it regularizes after 3 to 6 cycles, right? Same over here, right? You start them on hormone replacement therapy and they can have abnormal vaginal bleeding, right? Which can become cyclical, but it will normalize, right? It will normalize. If it continues to persist, you have to investigate. Or if they have risks of endometrial cancer, right? Smoking, early age of your menarche and stuff like that, right? All the risks of endometrial cancer, you need to do an endometrial biopsy. Okay. So again, it's a benefit, risk, benefit, right? So you know the risk factor, you know what to do. Good. Okay. You can consider other options like I have mentioned over here, like your T-sex, Mirena, and so forth for the bleeding things, right? And I talked about the endometrial sampling or biopsy, ultrasound, dependent on the risk factor. Mastalgia or breast pain can occur early, but it just goes away, right? It can occur early, but it just goes away by itself. Good. All right. Some special scenarios, right? Like migraine, it used to be like a contraindication. Now it is a relative contraindication, right? It is a relative contraindication. Okay. If the patients cannot take hormone replacement therapy at all, then like I talked about before, there are options venlafaxine, SSRIs, gabapentin, you name it. These are the non-hormonal treatment options available. Okay. Let's do this case before we end our session tonight. All right. 54-year-old female presents with severe hot flashes, night sweats, and mood disturbances, right? She is 2 years postmenopausal and is interested in starting hormone replacement therapy. Okay, all good so far? Let's see. Severe stuff. Okay, sounds good. Her medical history includes migraines, obesity, right? Migraines, obesity, and the sister who had breast cancer at the age 47. Wow. She has intact uterus. After initiating combined estrogen progesterone therapy, she experiences breast pain and light irregular vaginal bleeding for past 3 months. She remains symptomatic and asks for advice on continuing the therapy. Which of the following is the most important next step in the management of this patient, right? So you guys are saying discontinue the therapy immediately and refer to endometrial biopsy because of the risk of endometrial cancer. Okay. Switch to transdermal estrogen formulation combined with an IUD. Switch to estrogen monotherapy because of lower breast cancer risk. Stop all hormonal therapy and initiate escitalopram due to migraine with aura. Okay, someone has said that. Increase the estrogen dose and shorten progesterone duration to control symptoms and bleeding. Right? To control symptoms and bleeding. Okay, sounds good. Now let's take a look at this one by one. Right? Let's take a look at this one by one. So discontinue and refer to endometrial biopsy due to risk of endometrial cancer. Let's see. Does she have a risk of endometrial cancer, everybody? Yes, no, yes, no. What are the risks of endometrial? What, so before we do that, tell me what are the risk factors for endometrial cancer? All right. Okay. So some of the risk factors, obesity, maybe early menarche, late menopause, some of these things, right, are involved in it. None of that seem to be the case here, right? Obesity, sure, the person has obesity, but other than that, we don't see like smoking or anything major over there, right? So the risk of endometrial cancers doesn't seem to be like super high, right? Doesn't seem to be super high. It is sure there is some risk, but not super high. Okay, let's move forward. Switch to transdermal formulation. Okay, so what does transdermal estrogen formulation help with, everybody? It does what? It does what? We talked about it before. Transdermal estrogen formulation. What does it do? It reduces what? It reduces the good, bypass this liver, and it reduces low. No, tell me specific, guys. It reduces the VTE risk. Very good, Dr. Binayok. All right. It reduces the VTE or venous thromboembolism risk. Okay. So that is one, right? Next is Mirena IUD, right? Mirena IUD is the next one. All right, is the next one. So this is an interesting piece we can think about. Let's move to the next one. Switch to conjugated estrogen monotherapy due to its lower breast cancer risk. Okay, this is true, right? Only estrogen reduces breast cancer risk. That is true. But does she have a uterus? Everyone? Yes, no, yes, no. Does she have a uterus? She does, right? So giving estrogen monotherapy is not the greatest idea, right? So we are going to take C out. It's not the greatest idea. Stop all hormone therapy and initiate due to migraine with aura? No. Migraine is a relative contraindication, so no. Increase the estrogen dose and shorten progesterone duration to control? No, not at all. Okay, so none of these are true. So now let's go back to the question and take a look. So in our question, there are a couple things that are important. She experiences mastalgia and light vaginal bleeding for last 3 months. Is this abnormal side effect or it is a normal side effect? What do you guys think? Abnormal side effect or a normal side effect? Very good. It is a normal side effect, right? We wrote it, right? We wrote it. Vaginal bleeding and mastalgia are normal side effects, right? What are they saying? Options to reduce bleeding? You can consider Mirena to reduce bleeding, right? You can consider Mirena to reduce her bleeding. So over here, for progesterone treatment, you don't need to give her oral progesterone. You can just put a Mirena in, right? And it will control the bleeding. Check. So we fix the bleeding, right? Now let's talk about estrogen. Are we going to give oral estrogen or transdermal estrogen, right? Let's talk about estrogen. So she has risk of venous thromboembolism, right? Obesity, okay, is a big risk factor for her, right? So she has risk factor. So if we are doing levonorgestrel or Mirena IUD, transdermal estrogen will provide her better option than oral because it has lower risk for VTE. Okay, so option B sounds very promising. Let's talk about option A. Because of the side effects that she is having, will we just discontinue the hormone replacement therapy? Will we just discontinue the hormone replacement therapy? Yes, no, yes, no. Because of the side effects? No, right? Why? Because these side effects are common side effects, right? These side effects are common side effects. So what is the correct answer in this case, everybody? Correct answer in this case is B. Switch to transdermal estrogen, right? Combined with a Mirena IUD, combined with a Mirena IUD, right? So she has migraine with aura, which is a relative contraindication, right? Migraine with aura, which is a relative contraindication, correct? So we can consider transdermal estrogen because it doesn't cause strokes and stuff like that, right? She has family history of breast cancer plus obesity, right? So you can consider Mirena IUD for helping out with those risk factors. Mastalgia and bleeding are common side effects like we talked about, right? And only estrogen is not appropriate because she has a uterus, right? She has a uterus. Escitalopram, you can try it, but you have to make sure that you do the hormone replacement therapy first because she wants to continue it, right? She wants to continue. She asks for advice on continuing therapy. If she said she asked for advice on discontinuing therapy, fine. Move to something else, right? She's like, I don't want it, doctor. Fine. That makes sense. But she wants to continue with it. Does that make sense, everyone? Yes, no, yes, no? All right. Let's pause here.